and you should get something. Let's see. You should be able to join it. Okay. Oh, let me see if I can see what you said. Okie dokie. Let me see if I can. I am in the video call with you, so I just click this again. Okay, this one, join, take me there. Okay. Well, you should be able to, I've invited you, so you should be able to see it. And then I see you sent a message, accept. Here's the link to the Hangout. Hey. All right, bye. Okay, no worries. And you just have to use your camera too, I believe. I see you popping up. I see your profile. Okay. I see a blank screen on you too. Did you turn on your camera? I get it. Oh, I can hear you.
Oh, can you see me?
I can't see, but I can hear you. Oh, I can see you. Yes. Okay, I'm gonna hang up the phone. All right. Oh no, echo. Okay, I can see you. Fabulous. All right. See.
So sunny where you are. Where are you?
Yeah, it's kind of crazy. It's in my eyes. So lovely to meet you.
Likewise.
I'm glad this worked out. I will not keep you because I know you have a thing in 30 minutes, but I would love to buy you a drink and meet you in person in real life to thank you for this. So thank you for speaking to me. So I just wanted to talk to you and I'm just gonna ask you, who you are, what you do, and then just ask you kind of some of the disparities and what you see in the area. And my whole angle is that there's 2 DCs. There is the wards like 1 through 3 that have a lot of healthcare access and food access, and there's 5, 7, and 8 that are on the. So that's the genesis of what I'm doing.
Okay, so awesome.
Cool. All right, so tell me a little bit about yourself.
So I am a community pediatrician with expertise in pediatric obesity. I started at Children's and actually moved out to the District of Columbia back in 2005. I initially started working in both Northwest DC, in the on like the Euclid area near Adams Morgan, and also in Southeast DC, right off of Alabama Avenue and Good Hope Road. So I was able to really observe, even when I first moved out here, just what you mentioned, the 2 different DCs, because I worked in both Northwest and in Southeast. And working at Children's, and even before working at Children's, my one of my passions was about health and wellness and helping people just to achieve a healthier lifestyle. But especially working in Southeast DC, I noticed how many children were either overweight or obese. And even if they were normal weight, they really didn't practice healthy lifestyles. And so I became more engaged in that, did a lot more work in terms of pediatric obesity, served at Children's as the Associate Director of the Obesity Institute. And part of my task there was to create community-based intervention and prevention programs as it related to pediatric obesity. Did that until about 2013. For a variety of reasons, I transitioned out as a full-time pediatrician and pediatric obesity expert to sort of start my own thing. I really felt like the family approach, but that was not the model that we practiced at the time. And so I wanted to transition out to sort of create something that worked better to target families, because talking to the moms about what they needed to do for their children while they were eating fast food, I'm not even going to name the fast foods that they were eating because we'd be here for an hour. So instead of just being focusing on working with the kid, it was really working with the mom, the dad, the grandparents, anyone who influenced the child's eating behaviors. One of the great things at Children's was that I had an opportunity to work not just in terms of clinical practice, but a lot of advocacy work. So I worked on policy as it related to food and physical activity in the school setting. We talked about things in terms of the built environment. And so it certainly has helped me in terms of framing what I try to do now, which is to really look at all the social determinants of obesity as it relates to changes within the family.
I want to roll back and just ask you just a little bit, if you were to just kind of have to do side-by-side look between, you know, your past practice off of Adams Morgan Euclid and what you see now, in addition to obesity, do you see any other kind of stark differences in the health of those communities?
Definitely. I would say, especially over the past 10 years, even in Adams Morgan, you've seen a change in the demographics. So even within Northwest DC, you have seen a transition from one DC to another. When I was first at the health center in Adams Morgan, it was predominantly Latino and a good amount of immigrant populations from various countries within the continent of Africa. And now with the gentrification of the area, the $1 million lofts and townhomes that are there now, it has certainly changed the patient population seeking services in that Northwest corridor. But in Southeast, things really have not yet changed. So where I'm seeing improvements in terms of asthma, I'm not seeing as many patients coming in Northwest, because I still see patients in Northwest as well. I'm not seeing as many people coming in with asthma exacerbations. I'm not seeing in Northwest the same amount of children coming in with behavioral issues, diagnoses of ADHD, a lot of other stress-related disorders, a lot of things. It's completely different patient populations in Northwest compared to Southeast.
So understanding that your expertise is the provider, what do you attribute these differences to? I mean, the city is not that big. Why do you see such a why do you hypothesize, or rather you see such a drastic difference between the Northwest and your current patient population in Southeast?
I think it's a combination of things. I think the first thing is resources. So in Northwest DC, you can access farmers markets, grocery stores that have not just healthy foods, but healthy foods at a reasonable price. Healthy foods that you take home and you don't find out that half the bag of cherries have rotted as compared to in Southeast, because that's happened to me. When I went to the grocery store in Southeast, I'm not even going to name the grocery store, but I went there because I'm trying to support where my families go and sort of see what their experience is. When I get home and the outer part of the cherries are phenomenal, but as I empty the bag out and the other half are just nasty, it makes you wonder in terms of social justice, what decisions are made such that east of the river, they get a certain allotment versus, you know, other parts of the district. Mm-hmm. I don't want to get into like conspiracy theories and things like that, but I have to think that there are deliberate decisions that are made that allow or disallow the availability of healthy foods. And that isn't just in terms of obesity, but a child having access to healthy foods isn't just about weight. It's about that child reaching their full health potential. And so if a mother with her limited income has to choose between or take the chance on produce that may not be sufficient and adequate because it either rots quickly, or when she gets it home she realizes it wasn't what she wanted, it's not ripe, it's subpar, then the likelihood of her going back to purchase it again is significantly low. And a lot of times people say, oh, well, tell them to eat healthier. Well, what does that mean? Have you actually, as a provider, as a school teacher, whoever that person is, have you actually gone to the grocery store to see what that experience is? So I think it's a matter of resources and access. Physical activity. So in Northwest, like right across the street from our health center is a park, a very safe park that families feel comfortable in going. But in Southeast DC, it's not necessarily the same. And so again, you can't just say, go out to the park, your local park, and be physically active. Well, if this child's cousin just got shot, or whatever may have happened that was a bad thing around that park, down the street, right outside their apartment building, a family is going to be less likely to engage in those kinds of behaviors. And then when they deal with that kind of stress in an ongoing fashion, not only does it change them neurohormonally, and studies have shown that over and over again, that multi-generational effect of stress, but that's direct stress when those children are living in environments that are obviously not as safe as they are in Northwest DC. You know, in Northwest DC, they have street protections. They're now, with gentrification, which that term just drives me bananas. But, you know, when white folks move in, all of a sudden they zone areas, and not just anybody can park there anymore, right? So if you don't live on K Street, you can't park on K Street. But that's not the same in Southeast. Everybody and their mother can park in those neighborhoods, no question asked. In terms of police presence, they're certainly doing a better job. But within East of the River, there are also these challenging dynamics between the and African Americans. And it is, I mean, it's pervasive throughout the country, but especially when you have had your own negative experiences, it's hard to trust those who are supposed to keep you safe. And so then the question is, who do you trust in that situation? And it makes little ones, I love it when I ask a little one, what do you want to be when you grow up? And they say a police officer, because my sense is that they have not yet been jaded by living in an area where the police may not have been the ones they went to for their safety and protection. So I think it's a mindset. It's in terms of how we address certain issues as providers and facilitating conversations that may be a little uncomfortable, especially when there are non-African American providers in the clinical setting. Sometimes it's hard to have these conversations in order to address some of these disparities that we see within this tiny city.
That's amazing. That's amazing. So you talk about access to food. You talk about some education. What else? Like, if you could wave a magic wand, if you could really if you could direct policy or resources, what would you request in your areas to support your patients? Because I mean, a food fix could be a distribution fix, right? But stuff like public safety is a little bit more systemic. Trust with your providers, speaking a language that makes sense to your providers, health literacy on their end, but also being sensitive, to the cultures. I mean, what would you have a magic wand as your thing, how would you change, the climate of where you practice?
I think I would do a couple of things. The first thing is sort of starting where little ones start. So having sort of this cohort of pregnant mommies, right? And from the time they know that they have conceived all the way through, we address a lot of those social determinants that lead to chronic disease. So during pregnancy, what are we doing to manage that mom's stress? What are we doing to educate her, not on just eating healthier, but what is the role? And then from there, starting to have that conversation about the importance and the access to quality early childhood education, so that the same kinds of services that my mom in Northwest gets at her early childhood center, sign language, musical exposure, they're going to plays, et cetera, whereas in Southeast, some of these little ones are just sitting there being read to. Hopefully they're sitting around, and it's not the same level of engagement. And I have friends who take their children to both daycare centers in Southeast and in Northwest, and the dichotomy is just absolutely amazing. So making sure from the time that child is conceived all the way through elementary school, if there are the services the same? So making sure that it isn't based on income tax, it's not based on whose council person is most vocal. It truly is a equal distribution in terms of the resources, such that if a child is in Southeast versus Northwest, the school access, the school services are exactly the same, without anyone having to question what the motive is in terms of redistricting or any of those things. And then just continuing that child through, making sure that every touch point within that child's life, we're addressing income disparities. So for the parents, a lot of times when parents come to see me, it isn't just that their asthma is flaring up. Mom's stressed because she's missing out on work because the asthma is flaring up because her boss told her, if you miss one more day, you're fired. But in corporate America, or even for me, at Children's, if I tell you, look, my child is sick and I'm going to be out tomorrow, people might raise a bit of an eyebrow, but no one's going to threaten my job. But then if mommy's job is threatened, then that affects her ability to care for her child. So then making things supportive, even from the time she has the baby, breastfeeding support, all of those things that sort of kid glove that child from the time that they are conceived until they get off to college. I think if I could blink my eye and have that happen, I think what we would end up seeing, especially amongst children of color, is a generation that's risen up in a healthy environment that starts to sort of pause that multi-generational effect of stress that we see, that multi-generational effect of financial oppression, educational oppression. And then from there, they've learned better, because a lot of times, especially within, like I grew up, my mom was a teenage mom when she had me. My grandmother started having children when she was a teenager. But thanks to the good Lord, my mother appreciated the importance of higher education, even though she dropped out of high school at the start of 9th grade. She pushed me. And I think that for that reason, I pushed my patience. Although I was able to break that cycle of poverty and teenage pregnancy and all of those things, there are a lot of generations who have not. And I see that on a regular basis, especially east of the river. They have not yet seen people within their families, within their close circles, who've been able to fight it, to end it, to break that cycle. And luckily for me, there were resources made available to me. I moved from Louisiana to Southern California. The school system was much better. The support services were much better. There was more of an incentive for me to achieve. I don't know what my outcome would have been had we stayed in Louisiana, because I grew up in a very podunk town, not to diss my hometown, but the actuality is that there were things in place for me to allow for better success. My school that I went to is one of the top schools, or school districts in the state of California. And so that allowed me to achieve better. And I think that if we do that, put those things in place east of the river, paying close attention to how things compare, such that everything is equal. If I'm in Northwest versus Southeast, everything is comparable, then we allow those children to succeed in the same way that, you know, Becky and Amy and Josh do.
All right, I can't put that clip in there, but I appreciate what you're saying.
You can edit.
Like, ooh, ooh.
Oh, I was about to do X and Z format. Edit at minute 2. No, I'm kidding.
Oh, yeah, you know, the recording just didn't turn out. No, I'm kidding.
I just have the recording.
I just want to make sure that I got everything that because you gave me a beautiful amount of stuff, and just so you know, the video I submit can only be 4 minutes. So I'm not trying to cut you off. I just want to make sure I got everything. Is this gonna?
Oh, it's all right. You can tell. I especially with issues like this, I will talk and talk and talk.
No, I think it's important, because I think at the end of the day, do you feel, I get the sense that there's a lot of people like you and a lot of organizations like Shire that are trying to do stuff, but we're all siloed together. Could you see some benefit in us trying to actually say, okay, all these community resources and actually uniting them rather than trying to do everything in our own little bucket? Do you experience that a lot in your areas as well, service?
Yes. So working in silos has sort of been the MO for the District of Columbia, even within health organizations. And I'm not going to mention who, because I know we're on tape. But even with organizations, the health organizations themselves don't know what the other component within the same health organization is doing. So I'll go to a meeting and I will have heard from chronic disease folks in the same building who have no clue what the obesity folks are doing. And they're very either comparable or they're reinventing the wheel. And it makes no sense to me, because why are you repeating efforts, especially in a system where we have a shortage of resources? So if everybody's trying to achieve the same goal, why not pool together to make it bigger, better, and more effective? There's no need to compete. I think that there are enough slices of the pie as we tackle health disparities that it makes no sense that we don't work together. And right now within the Department of Health, I co-chair the obesity committee. And one of our goals is to pool these resources together so that at least we are aware of what the other is doing. And then the next step is to work together to achieve greater goals, especially east of the river.
Last question. One of the things that I've seen just working in communities and just, in general, I feel like there isn't a belief, there's not a lot of empowerment for patients, especially patients of color. Meaning, an anecdote, I was at this community meeting about breast cancer. And this woman said, I had this history of breast cancer. Literally everybody in my family's had it. I would like to get, my services, my mammographies. And the doctors looked at her like she was crazy. And it turned out that she had an advanced case of breast cancer. So do you think that there is room to coach patients on how to be advocates, coach providers on how to better listen, that kind of training as well?
I think it's both of those areas. Letting patients know that they are their biggest advocate, but also talking to providers so that they are accepting of a patient's role as self-advocate. My family being from Louisiana, they're still part of that whole old school, the doctor knows best mess. And that's so not, you know your body best. And so when I see families, when moms and dads come in, I will ask them, what do you think is going on? This is what I think. You know your child better. So what do you think is going on? And I will give a full explanation. And then I will also listen as they say, well, no, doc, I don't think that's it. I think a lot of doctors have to take their egos out of the room in order for that conversation to happen. Without that, we start thinking, oh, you're checking me. You don't trust me. And it's not a matter of trust, especially for people and their kids. Like I do the same thing with my daughter's pediatrician in a very respectful way. I think if it's respectful on both sides, a patient can successfully advocate for themselves and sometimes really direct the path of the medical care, because we will get caught up in something that we think is going on without taking into consideration that full picture and end up taking patients down a completely different path than the one that they should have gone down. And a lot of times if patients had said something, and my mother, we've had the same situation. My mom was on a cholesterol lowering agent. She decided she didn't want to take it. Didn't say anything to the doctor because she didn't want to hurt his feelings. And I was like, it's about feelings. It's about you, your cholesterol, and your heart disease. So what I need you to do, but she didn't feel comfortable. So instead, I had to advocate on her behalf. And certainly if that is needed, then someone in that family needs to be able to advocate. Not everybody has a doctor in their family that can, stand up for them. But that needs to be a real conversation. Like I think either insurance companies, as they insure folks, the Medicaid HMOs throughout the country, there needs to be some sort of body that communicates to patients, you are your best advocate. You as a parent are your child's best advocate, and follow through. And if a doctor gives you pushback, there should be a system where families should be able to call and be like, hey, this is the conversation that took place. This is what happened. If it's done in a respectful way. Now, have people gotten a little bowdy about it with me and no, what you gonna do is give me some antibiotics? Yes, we have had that conversation too. And we have, and I give them responses. I explain things to them. I don't just shut them down. I say, well, no, I understand what you want, but this is when this would be indicated. And these are the things I don't and I do see on your child's exam. And then they're like, oh, okay. So now if I saw this, then you are absolutely right. It's all in how we communicate with each other.
I'll leave you with this story. My dad's a physician, and he was working with a patient. And cholesterol wasn't, reducing. He put him on Lipitor, and he's like, I want to talk to you about your diet. He's like, yeah, when I eat Fatback, I just take 3 more pills. So that'll. My dad's retired now, but he was just like, I just cannot. So with that, I will thank you for taking the time. And
that's the best. That's one of the best I've heard.
I appreciate you. I hope to meet you soon in person. So thank you for the time.
You're very welcome. Mwah.